let's just do thyroid disease. So what I figured out about thyroid disease is that we have about out of the 500 endocrine points, diabetes ended up giving almost 196 points, and thyroid disease ended up giving almost 100 points. So between thyroid and diabetes, you've got almost 300 points, leaving the remaining conditions with 200 points. It definitely means that if you go into the AKT and there are 5 questions, 2 of them may likely be from diabetes, 1 of them will likely be thyroid, and the remaining 2 can be from any of the other conditions. And before I forget, someone during the break just phoned just to ask about the mocks for his friend. Please, your friends can join our mock. They should just message admin. They can join the mocks and they get a feedback report as well. It's just that the mocks are free for people who are on the Easy Learn program, but it's not free for people who are joining from outside. But yes, everyone can join the mocks. For the mocks, I've basically said how it works. So once the admin team are ready, they will send you the website. They'll send you the link, and all you need to do is go on that link and click it, and I think it will ask for your email. Once you fill in your email, it takes you to the exam site, just like you see on your AKT day. You read the instructions. Once you are happy, you click start. It starts to count down, and once the time finishes, whether you finished or not, your exam paper will disappear. What you will notice is if you try to enter that exam again with that same email, it won't work. So it means one person, one email, one exam. And so please be ready for it. And the good thing that we have done for everyone is that you can do it at your time. If you want to do it 2 a.m., it's fine. If you want to do it in the morning, it's fine. You can do it at your time, and you will have at least minimum of 5 days to write it. So don't be in a rush. The other thing is that we've not made it a standard 200 question exam, because we know many of you will be working, many of you will be busy. So within this September, all the mocks you will see are 100 question or 50 question mocks. In October, you will not see 50 question mocks. You may see some 100 question mocks, and you will see 200 question mocks, standard exam. And it will mean that you will need to do the same. You have to have the same environment, the same feeling, the same everything as your AKT. For the environment, you'll be the only one to create it. I'll tell you to go to a quiet room where you won't have disturbance, because some people's exam will be impacted by someone knocking on the door to ask for a key, which has taken 5 minutes away, and that can impact on your score. But the feedback we'll give to you, we will not know what has happened during your exam. So if you want to take your exam in the midnight when there's no disturbance, take it. If you can lock yourself in a room, lock yourself. You can stay back at work when everybody has gone and quickly take your exam, do that. So you create your environment yourself. We create the exam feeling for you, and we give you your results and the feedback. So for that candidate that asked about if his friends can join, please, the mock can accommodate as many people as possible. But let's go back to our focus for today. Our focus for this late morning is thyroid disease. And as I've said, I won't keep you here beyond 11 o'clock. I promise. We will not be able to cover all the thyroid points. But what I will do today is I will give you as many points in an as easy form as possible. The remaining points we'll cover during our drill. Some of the remaining points, while I'm running through tomorrow's endocrinology 2, I will mention some of them as well. And while I'm even doing some other topics, like today, you can see that as I was going through endocrinology, I brought in cardiology again, so you hear some of these points. But I'm just going to follow the format. So, well, interpretation of thyroid blood test, what we call thyroid function test, is the key point, is the basis. Well, if you cannot interpret this thing, I don't know how you want to answer one single thyroid question, unless if you've crammed. So I beg all of you to know the interpretation of a thyroid test. What is a thyroid function test? A thyroid function test is a test that contains T3, T4, TSH, and sometimes you can see the TRBs, the thyroid receptor antibodies. In if you request for it, you say thyroid function test plus antibodies, they will do everything for you. So it's got all the thyroid things that you need. It's a full package. That's why it's called a thyroid function test. But my friends, knowing the name thyroid function test and knowing what it is a different ball game from being able to interpret it. So this morning we are going to learn how to, and you can see that there's low, high, normal on this slide. Low, high, that's just the starting point, my friends. This morning you must have heard me say twice, you need to know biochemical reference ranges. I've talked about kidney function test. I went back to talk about gynae. Please, now I'm talking about thyroid. You will not know these things unless you know their reference ranges. So, because we are going to be doing thyroid today, let me just mention the reference ranges. Well, normal TSH is 0.4 to 4. In the exam, what may happen is they may give a slightly different reference range, which will not affect what you already know. It will never be more than 4.5 and to never be less than 0.3. That will not be a correct TSH. So if it's slightly away, it will not make your answer wrong. If you want to go and check, that's fine, but standard 0.4 to 4 normal TSH. The other major thing we need, because I don't want to bore you with too much reference ranges, is T4, 9 to 20. For the remaining, if you want to know it, spend some time, look at the reference ranges, learn them. But the one you need to learn this morning, I just want you to learn 2 this morning, then you can learn the remaining later on. TSH 0.4 to 4, T4 9 to 20. TSH 0.4 to 4, T4 9 to 20. If you know this, you are good to go. You can interpret any thyroid function test in the exam, even if you don't know T3. It's not very important. T4 9 to 20, and T4 is different from free T4. There's one that is 70 to 140. That's not the one we are talking about. We are talking of the T4 that is 9 to 20. That's the one you will likely see in your AKT and your Canadian exams. Okay, so what's the rule of thumb? The rule of thumb in interpreting thyroid disease or thyroid function test is anytime first of all, the TSH is the most important thing to look at first. Let me just establish that. TSH first. TSH first. Everybody has heard that clearly. So what's the next thing? I've looked at TSH. What's happening? The TSH is low. I've looked at TSH. What's happening? The TSH is high. What does this mean, my friends? Looking at the TSH is not important. In knowing what a low or high TSH means is the important things. So as a rule of thumb, a low TSH is generally a hyperthyroid picture. Learn it like that. It will help. A high TSH is usually a hypothyroid picture. So point 2 established. Point 1, the first thing to look at is TSH. Point 2, the next thing to check is, what is my TSH saying? Is it a hyperthyroid picture? Hyper is always low in thyroid disease. That's another way to know it. Although it says hyper, we expect it to be up, but the TSH is down. Hypo, although it says hypo, I'm expecting the TSH to be down, but the TSH is high. This is what we call rule 2 when we are trying to interpret thyroid function test. So now that you know that this is a hyperthyroid picture, you know the other one is a hypothyroid picture, let's start. For a hyperthyroid picture and hypothyroid picture, there are 3 very important things you need to know. But for hyperthyroid picture, there are 2 other less important things, or even 3, that we need to know. So let me just quickly start with the hyperthyroid because it seems to be more. Now, you've got a low TSH. you now know that that's hyperthyroidism. But what type of hyperthyroidism is it? Let's start from low TSH but normal T4, normal T3. Well, if you get a low TSH and a normal T4, your answer is automatically subclinical hyperthyroidism. What's that? Let me explain that in a nice way. Subclinical means this patient is not sick, but his investigation is abnormal. What's causing it? So they say he's not clinical yet, he's not sick yet, but he's around the point. He's around the borderline. He can become sick. They call it sub. So he has not met the clinical threshold. He is below the clinical threshold. He can fall into the clinical threshold or fall back to normal at any time. And so when you are seeing normal everything, low TSH, although it's a hyperthyroid picture, as you know, this is because it is subclinical. So that's subclinical hyperthyroidism. I hope that has helped as I've run my mouth like that. Well, let's go to, now that you know low normal or low normal. When you hear me say low normal, that's NNN. I mean TSH is the first, T4 is the next, and T3 is the next. So let's go to LHH. Of course, L is already making it know that it's a hyperthyroid picture. Rule 2 of our rule of thumb. Hyperthyroid. But what type of hyperthyroidism is this? High. For it to be high T4, high T3, it is a proper hyperthyroidism. That is what we call the classical hyperthyroidism. Everything is high. So we've got our hyperthyroid picture with everything high is classical hyperthyroidism. It's called hyperthyroidism. So I've told you two things now. I've told you when it's normal, it's subclinical. When it's high, it is hyperthyroidism. But how about a picture when it is low? So we've done low, high. We've done low, normal. What of low? Usually when there's low or high, there's a tumor somewhere. If it's low, there's a tumor in the brain. So that's what we call central hypothyroidism. If it's high, there's usually a pituitary adenoma that is producing TSH, it's producing too much TSH, and that's why everything is high. If it's low, the central causes is giving a negative feedback, and that's why everything is low. But I want to take you to a different realm. I want to show you a different picture. It can be low because a patient has become too unwell to produce thyroid hormones. If a patient is too unwell, his pituitary, his thyroid gland is not producing thyroid hormone because he's too unwell. We say his thyroid gland is sick. That's where the name euthyroid sick syndrome comes in. A sick thyroid cannot produce anything, my friends. Everything will be low. Unfortunately, that cannot be the picture in high, because if a thyroid is sick, it's not going to produce at all. So nothing can be high. Everything will be low because nothing is being produced. It's because the thyroid gland that produces is sick. Please, I've explained 3 top high yield hyperthyroidism picture in different ways. For any candidate that doesn't understand, please let me know. Just ask me questions, or during the drills, we'll talk about it further. During the drills, I'm just going to pick one of you, and I'm just going to say low, high. I'll be expecting that in 10 seconds, you tell me what that is. You say it's a hyperthyroid picture and it's hyperthyroidism. I say you low. Mrs. A low. She says, well, low, it means the thyroid is sick, and that's what we call euthyroid sick syndrome. However, it can be a feedback centrally. This feedback centrally is not very common. So usually the answer will be euthyroid sick syndrome. How will I know this question in the exam? You see, this is a difference between this course and many of the other courses. Some of the courses will just tell you low, and they will go away. We will tell you how the exam question will come. How will the exam question come? Well, it's very simple. It will be a patient that has been very unwell for weeks. You check the thyroid function, everything is low. Then of course you know it's a euthyroid sick syndrome. Okay, now that you know the top 3 that we want you to know, Sometimes there can be a hyperthyroid picture with only T4 high, and there can be a hyperthyroid picture with only T3 high. The other one is normal. What's that? If only T3 is high, it is a T3 toxicosis. That what we call thyrotoxicosis, T3. If the T4 is high, it is a T4 thyroiditis. How do you fail these things in the exam? That's why I can't think of. Let me go again. T3 high is T3 thyrotoxicosis. But if it's a T4 that is high, we're talking about T4 thyroiditis. The only other thing that can make T4 high like that is if the doctor is feeding the patient with T4, maybe they want to do a scan of the neck, or the patient is on a medication that contains T4. That's the only time it will be high. And then you have what we call T4 ingestion. Well, I believe this morning none of you will go into the exam hall and be jittery. If you shake, AKT will laugh at you, and this is not the plan. If you are jittery, the answers will never show up on the wall, no matter how jittery you are. If you stare at the roof so many times, you won't see the answer. Where will you see the answer is what we are talking about now. You need to find a way to understand it. So if this way I've taught you, you don't understand it, you understand it another way, that's fine. If this way I've taught you, you don't understand it, but someone else can explain to you, that's okay. But if there's no one that can explain to you, and you don't understand it in another way, and you don't understand it in this way, please accost me during the drills. Stop me. I will spend all the time to make sure that you understand it, please. So that's the hyperthyroid picture. And I've shown you the picture. I'm seeing it as a movie. This is how you look at this table, it's flowing in front of you. You are enjoying it. Now let's look at the hypothyroid picture. Of course, if hyperthyroid is low TSH, we said hypothyroid is high TSH. So I give you this patient, the information has come out, and you are seeing that there's high, normal, normal. We've said that anytime T4 is normal, is most likely going to be subclinical hypothyroidism. Don't even bother looking at the T3. But if you've got T3, just check if it's normal. If it's normal, T4 is normal, then your answer is subclinical hypothyroidism if your TSH is high. If your TSH is low, it will be subclinical hyperthyroidism. Right. Moving on, you see high, low, low, HLL. What's that? That is the opposite of your classical hyperthyroidism. But it's just that it is not called hypothyroidism, it's called primary hypothyroidism. Well, and I've talked about high, high, high. If you see high, 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 it means that there's something producing TSH that is causing everything to be very high. If there's something producing TSH, my friends, then what you need to do is to do a scan, do an MRI, and look for that thing that is producing TSH. Find it out, bring it out, and show the patient. This is what's causing everything to be high, high, high. Can I surprise you that in the AKT, they can bring out other pictures for you? There's something called postpartum thyroiditis. So basically, this patient can be pregnant give birth to a baby, and start to have a different problem, what we call PPT, postpartum thyroiditis. What do you see there? It's usually a hypothyroid picture. However, in the first 8 weeks post-pregnancy, it is a hyperthyroid picture. So imagine a patient having 8 weeks hyperthyroidism, and after 8 weeks hyperthyroidism, there's a second phase, 6 months of hypothyroidism. One candidate told me that's magic. That's not magic, my friend. That is a picture of postpartum thyroiditis. It usually may start with hyperthyroidism, and the second phase, it goes to hypothyroidism. We're going to talk about it. We're going to have a drill on it. We're going to play with it. We're going to enjoy it this morning before we go away. So I just thought I should mention that picture can come to you in the same question, because some of you would think, what's happening? Did they make a mistake? Someone will tell the examiner, I think there's a mistake in question 54. There is no mistake. That is postpartum thyroiditis. It can have both pictures in the same question. Well, another condition that can have the same picture but not in the same question is amiodarone. If you are here and you are not enjoying amiodarone like you are enjoying your cake, your red velvet cake, there's a problem. There's no way, there's no how we've not turned amiodarone. We've turned it so much that candidates have found their way of playing around with it. The last drill we're doing, one candidate said, "This is how I know it." Another candidate said, "This." Everybody were arguing that my own way of knowing amiodarone, everything about amiodarone, is the best. This is how learning should be. Everybody should know how their own codes will, how things work for them. So the amiodarone teaching that we originally did, we say know the 10 P's associated with amiodarone. If you don't know it and you're in this class, just message one of your classmates and say, "Please, can you tell me the 10 P's of amiodarone?" It will come out. Amiodarone is too high yield for you not to know. It's dangerous. It's self-harm. It's not right. It's unfair to yourself and unfair to the Easy Learn community. Please know everything about amiodarone. I beg you. Amiodarone is a medication, and when we're talking about it, it causes both hypo and hyperthyroidism. Well, I just thought I should give you a picture of a few other ones. These are the main ones. As I talk, as we do the drills, I'll show you other pictures that you've never seen before, or you've seen before, you've forgotten. I'll remind you. So let's move on. That's the interpretation. Please, this is going to come out. This slide should be your best friend if you don't know this interpretation. Play around with this slide. On the morning of every week, every day of this week, look at this slide just for 2 minutes. Every morning, just look at it. Once you wake up, before you do much, just look at it. Just look at when your husband says, "What are you doing?" Say, "I just want to look at the thyroid function test interpretation." When your children say, "Mom," say, "Wait for a minute, I just want to look at the thyroid function test interpretation." You need to look at it, my friends. Okay. In the AKT, thyroid disease can come out in any way. They can bash you. They can hit you on the head. But when they want to hit you on the head, when they see a helmet, they leave you alone. The helmet is your knowledge. They can decide to smoke you. When they want to smoke you, they see that your skin is too tough. They leave you alone. They say, "We are wasting our time. We can't smoke this one." When they want to drill you, they put you in on an interrogation table. They give you a question. Other candidates are sweating. They know that the question may defeat them. You are smiling. AKT becomes defeated. It starts to get weakness. It starts to behave as if it has hypokalemia. So, my friends, you need to be able to defeat thyroid disease in the exam. And the knowledge you need to be able to defeat thyroid disease is very, very simple. I've broken it down into simple points. In fact, what I've done is I've not overcrowded the points. I'm going to give you about 60 to 70 points here. And then in the drills, we're going to discuss the remaining about 30 to 40 points. Okay, so hypothyroidism picture, all of you know it. Why should I waste so much time on putting a picture of hypothyroidism in front of you? You know everything becomes slow. You know that this patient starts to gain weight. You know that this patient has cold intolerance. You know all those things. So because we have so many things to do, let me focus on what matters. What do candidates fail? Candidates fail the treatment. A patient has come to with hypothyroidism. You've done a test. Thankfully, you were able to know that once TSH is high, I'm dealing with hypothyroidism. Then you look at it very carefully. You can see that this is a hypothyroid picture. I say, good. I told you the first slide was the main thing, because if you cannot interpret a hypothyroid, nobody will tell you the patient has hypothyroid. You are joking if you are waiting for the AKT to tell you the patient has hypo. You need to interpret they need to know that you know what you are doing before they give you MRCGP, my friends. MRCGP is easy to have, but it's only easy to have when you have the knowledge for RCGP to say, "Yes, can you shake our hand? Congratulations. We think you know what you are doing. Take this certificate." It's for people that know what they are doing. And so the way to know what you are doing to hold that MRCGP certificate is to have the knowledge of thyroid disease, my friends. So hypothyroidism is a patient that has come in with a biochemical picture. You've been able to diagnose hypothyroidism. What do you do next? That's the big question. You need to treat this patient. Now, I stopped because I want to tell you, I want to beg you, because the only thing I can do is to beg you. Never treat hyperthyroidism in the practice unless you are giving symptom relief, what we call propanolol or beta blocker. But treat hypothyroidism in the practice if the patient does not have coexisting heart problems. Someone did not hear me, so let me just repeat it carefully. Hypothyroidism is the GP's job. That's what I'm trying to tell you today. But hyperthyroidism is the specialist job. How do you now fail it in the AKT? This is why I begged you before I said it. Your job is hypothyroidism, treat. The specialist job is hyperthyroidism, let them treat. Some candidates in the GP practice, they say, well, I'm an old GP, I'm going to start carbimazole. That's GMC. They may come knocking on your door if there's a problem. Carbimazole is not a very easy medication. My friend, when you use propylthiouracil, you need to know it. But if you don't know so much about it, it's a specialist treatment. That's the only thing that if you don't know anything about, you should know that these things are specialists, not you. Let the specialist write to you and say, well, I thank you for starting propanolol because this patient has palpitation. This patient has excessive sweating. This patient has been feeling unwell. Thank you for starting propanolol and thank you for starting at the right dose. Can you please add carbimazole? Can you please add propylthiouracil? That's what the secondary care would tell you in their letter. By the way, please, I've tried not to do a little here, a little there, but I'm constrained. I need to just do a bit of it. Propanolol is high yield in your exam. See, this patient that's coming with palpitation is not always thyroid disease. It can be pheochromocytoma. And I've told you how to remember pheochromocytoma is to use the pheo in front of pheochromocytoma. The P is palpitation. Can you see that hyperthyroidism has got palpitation, but pheochromocytoma has got palpitation? So how do you differentiate them? Going on, the H in pheochromocytoma is hypertension. Don't fail it in the exam. Well, if you've decided to fail the H and you say, well, I can't remember hypertension, there's another H, my friend, it's headaches. Pheochromocytoma is a cause of headaches in the AKT. Don't fail the exam. Some people think the only cause of headaches in the AKT is migraines. Some people think the only cause of headache in the AKT is Cushing's. Some people think the only cause of headaches in the AKT is a patient that has got tension headaches. No, that fat girl who is on combined oral contraceptive, her BMI is 38. She has idiopathic intracranial hypertension. It's a cause of headache. Why do you not think that glaucoma, after I've mentioned it, I begged you, why do you not think that glaucoma is a cause of headache? How do you even forget that head trauma can cause headaches? Brain tumor is a cause of headaches. That patient that has early morning vomiting, or that patient that has been having projectile vomiting. Look at this. This is a 360 degrees. How do you become unfair to yourself? You get into headaches, you don't play around with it. But what took me here is pheochromocytoma. What is the A? The A is anxiety. Anxiety in the exam, low mood, think depression. Anxiety in the exam, think certain medications. Anxiety in the exam, think pheochromocytoma. Anxiety is everywhere in your exam. How do you not know at least 40 points about anxiety? What are you doing? And if you go and treat anxiety with propanolol in the AKT, I've said it before, you failed the question. The first line treatment is SSRIs. Don't fail it. Please, I've tried not to get into a little here, a little there, but I can't. Please, let me just run my mouth a bit about the things, some of these things. You can't fail them in the exam. You see that the E in pheochromocytoma, the pheo, E, is excessive sweating. How do you fail a question on hyperhidrosis? Management of hyperhidrosis, aluminum chloride, first line. That's what's in your roll-on. This patient said, I've used aluminum chloride tablet, I've used aluminum chloride cream, I've used aluminum chloride. She said, doctor, is not working. What can you fall back on? My friends, think botulinum toxin. This is why you need to know the indications of botulinum toxin. It is BASH. Blepharospasm is an indication, my friends. Achalasia is an indication, my friend. Spasmodic torticollis is an indication, my friends. The H is hyperhidrosis. How do you fail these things, my friend? I want to beg you to be good. Being good is having everything at your fingertips. Don't give a space for anything. If they take you to CKD, you hit them. They take you to pheochromocytoma, you smash them. They want to take you to migraines, you play dirty. They may say, well, he doesn't know a bit of pediatrics. Tell them you know everything about Kalman's and Klinefelter. How do you fail a question on GERD in the exam? You don't know the difference between gastroesophageal reflux disease and a child that is having reflux due to food, the diet. You need to know everything about it. You need to be good. They take you to gynae, you know everything. You know the lumps in gynae. You know all the infections. You know what Bartholin's cyst treatment is different from the treatment of Bartholin's abscess. They may want to trick you. They may take you to a place, men's health, that you don't know. You tell them you know everything about PSA, cycloperon acetate. When do you use it? You need to know, my friends. It comes out in your AKT. How do I know? It's on the RCGP website. I just said I should run my mouth. That anytime you are thinking about palpitation in thyroid, is not just thyroid. Anytime you are thinking about excessive sweating in pheochromocytoma, other things can cause excessive sweating, including certain medication you give the patient. How do you give the patient a medication that causes excessive sweating and you are going to investigate pheochromocytoma? What are you doing? Okay, please don't forget pheochromocytoma is one of the 12 secondary causes of hypertension. I treated 15. If you were not in that class, you go to and watch the video. Secondary causes of hypertension. You need to know all of them. I didn't just list them out. I told you how it will come in the AKT. I told you that if it's a patient that has pheochromocytoma, his hypertension will come as the question will say he has palpitation and they say in his past medical history he has a diagnosis of hyperhidrosis. How do you not know that the question is telling you about pheochromocytoma causing this patient's hypertension? By the way, the rules of hypertension are still the same. We are still following the same guideline, but some candidates do not know everything NICE has said about hypertension. I'm going to treat it after the mock. You're going to see one of the questions will focus on some of the rules of hypertension. So can I move away from pheochromocytoma and move back to thyroid disease, my friends? Thyroid disease in the AKT, we're talking about hypothyroidism. I've said you need to treat. How do you treat? Levothyroxine is the answer in the AKT. Now, there's a question in the AKT. They know that you know levothyroxine, so they won't give you that question. Someone is thinking, well, this AKT is going to be very easy if this is what they are going to be asking. No, my friends, that's not what they'll be asking. They want to know what dose you will start this patient on. I will tell you now. The dose you start a patient on is dependent on their age. Is the patient greater than 50? Please start at 25 micrograms and increase. If the patient is greater than 50, start low dose. That's what I'm trying to say. 25 microgram is low dose levothyroxine. Then you can increase with time if you need to. Why? High dose levothyroxine, you are just going to punish that patient. Well, if your patient is less than 50, is a younger patient, then you can go a bit more aggressive. Do 50 to 100, depending on what you are seeing in front of you. How bad is the picture? So you can do 75. Most candidates will do 75 because 75 is in the middle. But for your exam, know that it can be between 50 to 100. Don't fail the question. And if you're expecting them to give you a range, they won't. They'll give you 100, it's correct. They'll give you 75, it's correct. They'll give you 50, it's correct, my friends. It's because it's between 50 to 100. So I've basically told you about hypothyroidism. You know how the picture will come. But what I've told you is the management. I've told you that you are to manage it. You did GP training, and I've told you how to manage it, what to use to manage it. Don't fail it in the exam. That's hypothyroidism if it's what we call primary hypothyroidism. Manage it that way. Can I tell you now that I've mentioned levothyroxine that don't give iron within 4 hours of giving levothyroxine? It will inactivate it. Some people don't know that the questions they ask in the AKT are simple questions. They've read the whole of hypothyroidism, but they've forgotten to read just a small note beside the page they were reading, which says avoid iron within 4 hours of taking levothyroxine. It inactivates it. They failed the question. because they don't know that iron and levothyroxine is a no-no. Don't be like them, please. Know which things affect which medications. Well, I think I've run my mouth a bit on hypothyroidism. I've told you how to start. I've told you where to start, and I've told you if the patient has a coexisting cardiovascular disease, refer to the specialist. Can I just move on and talk about the difference between subclinical hypothyroidism and subclinical hyperthyroidism? My friends, if you were listening to me in the slide before now, you would have seen that subclinical hypothyroidism simply means that T4, T3 is normal and your TSH is high. For subclinical hyperthyroidism, T4, T3 is normal, but your TSH is low. That's fine now. You've interpreted it. Because in your AKT, they won't write this word subclinical, underclinical. It won't say all this hypothyroidism word. It will just give you number T3, T4, TSH. Interpret it. And that's why I told you, if you don't know normal TSH is 0.4 to 4, you are doing yourself. If you don't know that normal T4 is 9 to 20, what are you doing in the exam? Do you want to be a spectator? You need to know them. Because if each time you click down on that drop box, you are wasting your time. Don't do it. Have it at your fingertips. It's easy. If you look at it every day for 3 days, you've known it. Trust me. Some people will gum it on the head of their beds. That's fine. Some people, when their alarm rings in the morning, the first thing is they will go and check it until they've known it at their finger. Anyhow you want to know, just know it. The end justifies the means. Anyhow you want to know it, just know it. If you want to know it anytime you are cooking, that's what you'll be doing. That's fine. If you want to know it by listening to these easy learn videos, that's okay. Just know it. Well, what is the difference between subclinical hypothyroidism and subclinical hyperthyroidism in terms of treatment? That's my interest. Why is it my interest? That will be your AKT question. How do I know? The RCGP has said it, that candidates are not doing well when it comes to subclinical hypothyroidism management. So let me tell you the answers very quickly so that in the exam you feel focused. In the exam you feel confident. In the exam you feel good. When you see subclinical hypothyroid, what do I do? My friend, it's dependent. Oh, please, I may forget and not come back to hypothyroidism. Can I talk about hypothyroidism in a pregnant woman, then come back to this point? I beg of you. In a pregnant woman that has hypothyroidism, please start treatment immediately. Because if anything happens to her baby, the GMC will come knocking on your door. Why I say start treatment immediately is that some candidates will say, Madam, let's do your TSH, let's do your thyroid function test, let's see what it is now. No, don't do that. If she's already on treatment, what you need to do is to increase. That's the AKT answer. That's the QE1 answer. That's the answer in any exam. That's the same thing practiced in the US. Hypothyroidism, increase dose immediately, even before you see the result. Don't worry about seeing the result, just increase. Because whether you see the result or not, you will still have to increase. So increase. So the AKT question, the answer option A will be wait for the result and increase. That's wrong. Option B will be wait for result. If normal, don't increase. That's wrong. Option C will be increase either ways. That's correct. But the question in the AKT is still not that. What's the question? How do you increase? I will tell you this morning. My friends, what you need to do is, there are two ways of increasing. It's either you use the dosage, which is in micrograms, or you use percentage of the present dose she is on. Someone is getting confused. So let me break it. I like to make your life easy. For the AKT, make your life easy. So this kind of thing now, they say, how do you increase? You are using 25 microgram lowest or 50 microgram highest. That means increase by between 25 to 50 microgram. It means that if she was on 50, 75 is the correct answer. It means that if she was on 50, 100 is a correct answer. So someone will go and cram increase by 25 microgram and they'll put 100 in the exam. They'll fail it because you can actually increase by 50 microgram. So it's a range 25 to 50 microgram. How about the other way of getting it? The other way of getting it is to use 30% or 50%. So between 30 and 50%, anything between that, that's how you can increase. What do I mean by this? 30% of the current dose she's on, add it to the current dose, that's your increase. 50% of the current dose she's on, add it to your current dose, that's your increase. 45% of the current dose she's on, add it to the current dose, that's your increase. 38% of the current dose she's on, calculate it, add it to your present dose, that's your increase. So anything between 30 to 50% can be the increase. I don't think any of you will be confused now that it's been so simple. So I just thought that if I don't talk about it, because there's no slide, and of course this slide is for me to run my mouth. It's been made like this so I can run my mouth, but it's to guide how I run my mouth. Otherwise, I run my mouth to another area, and I forget that we need to finish hypothyroidism, and I keep you here till 12. So this is a time, something to constrain me and make sure that I move within time. But sometimes we just need to go out of it, because learning is a little here, a little there. So let's go back to subclinical hypothyroidism, my friends. You know how to get it. You've seen the patient. There are rules of management of subclinical, and this is hypo. You can see how I pronounce it. I don't pronounce it in a way that will be confusing to you. When I say subclinical, I say hypothyroidism, so that you don't mix it with hyperthyroidism. Please, this is hypothyroidism we are talking about. Okay, subclinical hypothyroidism, there are few rules you need to know to be able to treat. What are those rules? We are coming back to the rule of TSH. You need to have the TSH, and three things that can happen. There are three pictures in the AKT that can happen with the TSH. What's picture one? I'll tell you. Picture one is that the TSH can be greater than 10. If you've seen the TSH greater than 10, say good. Good. What else will you look at? Go and look at the age. TSH greater than 10 in a patient less than 80 years, treat with levothyroxine. Can I repeat that? TSH greater than 10, patient less than 80 years, treat with levothyroxine. Someone is not getting it. The question will say, if there is a patient who is a 72-year-old who lives in Wicktown, has presented to you with the following, it will be a short question with the following blood picture. You see the TSH, you see the T3, you see the T4, you say, oh my God, this is subclinical hypothyroidism. But that's not what they're asking you, my friend. Don't waste time there. So what are they asking you? Just go, what they're asking is to, can you identify that TSH is greater than 10 in this patient that is less than 80, 72? Yes, you can. What you need to do is give him, so it's subclinical, but give him levothyroxine, hand him over pills of levothyroxine. Now, one candidate has forgotten that that patient has iron on his medication list. What are you doing? If the patient has iron on the medication list, tell him that you need to stop it now. We will commence iron. I will tell you how to commence iron. You can use iron at least 4 hours after. Don't use it in the morning at the same time with your levothyroxine. At least 6 hours after you've taken your levothyroxine, then take your iron. He says, okay. By the way, iron is high yield. You need to know everything about iron. You need to know the difference between iron deficiency anemia and hemochromatosis. I've said it before. When is total iron binding globulin high? Which one is transferrin saturase? When is it high? Is it not in hemochromatosis? When is ordinary transferrin high? Is it not in hemochromatosis? What is the investigation for hemochromatosis? When do you want to do genetic testing, what we call HFE? You need to know. Is in relatives. Is in relatives. When you want to do a full iron profile, just you do full blood count, do a full iron profile, is when you're trying to check for iron deficiency anemia. By the way, the causes of iron deficiency anemia, they are too much. Worms, if you don't know, cause iron deficiency and anemia. Ankylostoma duodenale is a cause of iron deficiency anemia. The Westermanni lung fluke is a cause of iron deficiency anemia. There are two hookworms, the old and new hookworm. They all cause iron deficiency anemia. So don't always look at even Taenia solium, tapeworm. It's a cause of iron deficiency anemia. Please, if you have forgotten that the commonest complication of celiac disease is iron deficiency anemia, don't write the AKT. Please don't do. You need to know everything about celiac disease. Everything. I beg you. Well, some people don't know that one of the commonest causes of iron deficiency anemia is cancer. Do a Q-fit for that patient if they don't meet the guideline. Otherwise, it's a 2-week wait. The rule is WARIC. That's the acronym, WARIC, 2-week wait. Well, there are other causes of iron deficiency anemia. There are about 35 at my fingertips now, but there are up to 70. If you know at least 50, go into the AKT, go and smile. Why would you fail a question? But that's not our focus. Again, hemochromatosis management is not our focus. Know the management. Right. So what has driven us into iron there is that iron and levothyroxine are not friends. So whenever you go to subclinical hypothyroidism, please stop iron when you want to give levothyroxine. Let's look at the second picture. In the second picture, TSH again is high, is greater than 10. But this patient is over 80 years. Don't treat. A patient who is over 80 years with a high TSH, picture 2, don't treat. So the first one is lower than 80, treat. Higher than 80, don't treat. But this is only dependent of if the TSH is greater than 10. How about a patient where the TSH is high? Because normal TSH is 0.4 to 4 to 0.4 to 4. I know some candidates they are still not used to it yet. It's 0.4 to 4. It's not hard. So how about a candidate that has at least 6, for example? That's high because it's more than 4, but it's lower than 10. What do you do? So a candidate that has TSH less than 10, but is got the picture of subclinical hypothyroidism, that one will now depend on symptoms. Is it symptomatic? Treat. Is it asymptomatic? Don't treat. Is it greater than 80 years old? Seek advice if it's symptomatic. If it's asymptomatic, don't treat. How difficult is this thing I've said? If someone wants me to repeat it, let me just run over it. TSH greater than 10 plus patient less than 80, treat. TSH greater than 10 plus patient greater than 80, don't treat. Just monitor the patient. TSH less than 10, what you need to now look for is the patient symptomatic? If symptomatic, treat. If asymptomatic, don't treat. If the patient is greater than 80, if they have symptoms, treat or seek advice. If they don't have symptoms, don't treat. Simple and short. What is the contrast? Subclinical hyperthyroidism is a total different ball game. If you use the rule of subclinical hypothyroidism to go and manage subclinical hyperthyroidism, you've automatically failed the question. Don't tell anybody. What do I mean? If a patient comes out with subclinical hyperthyroidism, what you just need to do is very simple. It doesn't have headache like hypo. All you need to do is simply repeat in 2 to 3 months. Why? Subclinical hyperthyroidism is usually transient and will usually become normal after some time. So my friends, in the AKT, you can see the difference between subclinical hypothyroidism and subclinical hyperthyroidism. Don't mix them up. What candidates do is they forget, they mix them up. They go and use the rule for hypo to treat hyper. Don't do that. Hyper is very easy. Hypo is the problem. Remember, anytime it's hypo, it's always a problem. Hypotension, they will collapse. But hypertension, they are walking around. Hypokalemia is super dangerous. Hypocalcemia, they can die from there. They can die due to what we call long QT syndrome. They can die due to constipation, high thirst, and generally feeling unwell. They'll become drowsy. They'll just have delirium. They'll go from there. So hypo is the dangerous one. And that's why you have to treat it more aggressively. Hyper, just chill. Take your ice cream, repeat in 2 to 3 months. Again, you've repeated in 2 to 3 months, it's still there. Don't bother yourself, be repeating yearly until one of the following two things I'm about to say happen. Outcome one, it can become normal, in which you go back to not investigating this patient again. Or outcome two, it can become hyperthyroidism, in which you would treat as hyperthyroidism. Someone has forgotten the treatment just now. Is to refer, my friend. Don't give carbimazole in primary care. Give propanolol, refer. Okay, well, the only reason why hyperthyroidism falls out in the AKT is because of OHA. What is OHA? OHA, I'll tell you. It is osteoporosis, heart failure, and AF, atrial fibrillation. It is a cause of OHA. And this is the most significant importance of subclinical hyperthyroidism. In fact, some people are beginning to say, please, if subclinical hyperthyroidism is lasting too long, why don't we treat? So if you check some local guidelines, some places will tell you that you should start to treat or you should refer if they have 1, 2, 3.
Please, what is
Because
OHA again, Dr. Leko?
osteoporosis, heart failure, and AF, atrial fibrillation. Now, I tell you a question in your AKT, they give a picture of subclinical hypothyroidism. It's a lengthy question, 2 paragraphs. They say which of the following is associated with this condition above, and someone doesn't know it's heart failure. I will be pained. Heart failure is the commonest association with subclinical hyperthyroidism because hyperthyroidism will cause silent palpitation. Subclinical hyperthyroidism will cause silent palpitation. The silent palpitation will over the time start to cause the heart to fail. Heart failure. How do you not know that the palpitation is the one that is causing the AF? What are you doing? Osteoporosis, please, osteoporosis is high yield in the exam. Everything about DEXA scan, no. The T-score, you need to know. Please, I beg you. How do you go into the exam? You don't know the difference between frax and Q fracture. What of the predisposing risk factors for osteoporosis? In male, it is 75. In female, it is 65. You can see that I know these things at my fingertips. Wake me up, I will spring to action. I'll tell you 15. Let me try and tell you some now. Hypertension is a cause of osteoporosis in the exam. Diabetes is a cause of osteoporosis in the exam. Certain medications like tamoxifen, they are a cause of osteoporosis in the exam. How about that patient that basically has drinking alcohol, lifestyle problems? Alcohol is a cause of osteoporosis in the exam. How about smoking? How do you fail it? Many of the electrolyte abnormalities, they are a cause of osteoporosis in the exam. Many other conditions, apart from the ones I've mentioned, including, I've mentioned diabetes, including bone problems, rheumatoid arthritis, osteoarthritis, they are all causes of osteoporosis in the. How do you now fail it? By the time I get into musculoskeletal, we start to do rheumatology, you will discover that because I've been running my mouth, I've already covered the topic. You are hearing it for the second time. This is fingertips experience. So OHA is the complication of subclinical hyperthyroidism, and that is our fear. We don't want the patient to have osteoporosis, heart failure, or AF. Well, now let me not spend too much time. There are a few other points which are not very high yield. I've told you I will do that in the drills. That's why don't miss the drills. But they give you a question in the AKT. They say this woman is pregnant and she's vomiting. Someone has failed the question already, because I can hear a candidate saying, I think the answer is Graves' disease. Well, it can. Another candidate is arguing, saying, no, the answer is hyperemesis gravidarum. Well, it can. It depends on what they give you in the question. Well, if a patient is vomiting, abnormal LFT, and the patient has never had any thyroid problem before, your answer in the AKT is hyperemesis gravidarum. If they write, they start to talk about a thyroid picture, raised, so that thing on their slide is raised TFT, not LFT. So raised or abnormal thyroid function test in a patient that is vomiting. The patient, you look at it, you look at the biochemical picture, then you see somewhere they wrote HCG. The only reason why HCG is there is because they are trying to tell you about hyperemesis gravidarum. Don't fail it in the exam, my friends. Hyperemesis gravidarum is not too difficult. Hyperemesis gravidarum is that lady that is vomiting in early pregnancy. Hyperemesis gravidarum, they can try to draw you dirty, they can try to pour sand on you. Make sure that you defend yourself. Tell them, what are you doing? Sit down. Hyperemesis gravidarum is very simple in the exam. The questions they can ask you about hyperemesis gravidarum can be the triad of diagnosis. What's that? She should have had 5% pre-pregnancy weight loss, dehydration, and electrolyte imbalance. Hit AKT on the head, knock it. What did I say? The trial to diagnose hyperemesis gravidarum is 5% pre-pregnancy weight loss, dehydration, and electrolyte imbalance. I've known it since 2020. I've not forgotten. I saw a patient with hyperemesis gravidarum. I went on to the guideline. I saw the definition of hyperemesis gravidarum. I've not forgotten. 5% pre-pregnancy weight loss plus dehydration plus electrolyte imbalance, hyperemesis gravidarum. Diagnosed. Simple. But that's not the question they want to ask you about hyperemesis gravidarum. What do they want to ask you? They want to ask you, what is the treatment? My friends, you need to know the first line and second line treatments. It comes out. It comes out. How did I know it? RCGP website says it. Well, the first line treatment are the P's. First line treatment for hyperemesis gravidarum, think about promethazine. Think about the phenothiazines. What are the phenothiazines? Prochlorperazine. So those two P's, don't forget them. Promethazine, prochlorperazine, they are all answers in your AKT. Well, if they want to make it a bit difficult, they push you to the C's. What are the C's? Cyclizine is a first line. Chlorpromazine is a first line. So what have I just told you? In summary, PC is the first line for management of a patient with hyperemesis gravidarum. How do you make it difficult for yourself? Prochlorperazine, promethazine P, chlorpromazine, cyclizine C. They are all oral. Enjoy yourself when you are reading for the AKT. My friends, they can bring out a medication you've never seen before. If you see a medication called doxylamine, it's not the answer unless doxylamine is used in combined therapy with pyridoxine. Pyridoxine is your vitamin B6. So you're seeing vitamin B6 alongside doxylamine. It is an answer first line treatment in the AKT. Although not popular, I won't be expecting any of you to prescribe it in the GP practice. Well, they can say the patient has reacted to all first line medication. You need to know second line. Metoclopramide is the second line. By the way, if you do not know why we're afraid of using metoclopramide in the AKT, go and know. It's because of the D2 antagonist effect. Metoclopramide will behave like haloperidol. Metoclopramide will behave like chlorpromazine. Metoclopramide will behave like clozapine. Can I say something now? I've said clozapine. I know I'm giving you too many points. You need to be hearing this point every day. Clozapine is a cause of agranulocytosis in psychiatry. But what is the cause of agranulocytosis in endocrine? Is carbimazole. Carbimazole is the endocrine cause of agranulocytosis, as clozapine is the agranulocytosis causing. How do you feel it? Look at this easy distinction. Carbimazole, which is our medication that we are using to treat hyperthyroidism, it causes agranulocytosis. It does, my friends. Well, I just thought I should just chip that in now that I remember, because as I'm going, I'm just remembering too many things are coming to my head. This is how in the AKT, as you read the first word in a question, if 50 things have not come to your head, you have a problem at that point. There's an issue. 50 things are supposed to come to your head at once. All of them saying, use me, use me, use me. You say, wait, you tell them, wait a minute. You read on to the end of the first sentence. You streamline it. You cut it down to 20 things. They are still saying, use me, use me, use me. You read the second line, you see the clincher. Only 4 things are in your head. If at that point there are still 4 things in your head, go on to read the third line. But by that time, most people, only one thing will be in their head when they are reading second line. Some people, all they read is first line and last line because they know clinchers, they know cliches, they know how to use the systems. and the system works for them. Well, let's move back to our patient who has been vomiting. Hyperemesis. You can see it's a little here, a little there. How do I tell you that hyperemesis gravidarum thyroid function test is mirrored by HCG? That's what happens here. How do I tell you that without just touching hyperemesis gravidarum, which is super high yield? It will be unfair to use yourselves. My conscience will prick me. And that's why I've said sometimes I cannot resist not talking about these topics, because that may be your question 16. And you may not be available when we are teaching hyperemesis gravidarum. I may be teaching hyperemesis gravidarum. Everybody may be tired. You may not be listening. I may be about to teach hyperemesis gravidarum and say, okay, we've tried today. Read up the rest on your own. You've missed hyperemesis gravidarum. It's your question 16. You can see that now I'm talking about hyperemesis gravidarum. I've not talked about everything. I've talked about the ones that will come out. The ones that will come out, you will know. The triad will come out. The medication of the treatment will come out. So second line, I've told you metoclopramide is a second line treatment, and you need to know it. Another second line treatment that can come out is domperidone. Domperidone is a treatment for hyperemesis gravidarum if you've tried the first line and it's not working. So oral domperidone, oral ondansetron, oral metoclopramide are all answers. How do you remember the second line? Is DOM or mode. Metoclopramide, ondansetron, domperidone. If you are going the other way, domperidone, ondansetron, metoclopramide. You can't forget it. Remember that ondansetron is not safe in first trimester. Don't make a mistake in real life and in your AKT. Well, I just thought to tell you that if you see high thyroid function test, don't let the question sway you. Don't let the question throw you off balance. Don't let the question hit you on the floor. Some people allow AKT questions to hit them on the floor. Don't fall. Don't fall for the question. That's hyperemesis gravidarum. Otherwise, if it's a patient that is already known to have hyperthyroid problems, it's Graves. It's Graves' disease that's causing her vomiting and abnormal TFTs. Let me see if we can say, thyroid peroxidase. This is where I want to now run my mouth. In the AKT, thyroid peroxidase antibodies Hashimoto's. In the AKT, thyroid peroxidase antibodies, it is Graves. In the AKT, thyroid peroxidase antibody is what we call postpartum thyroiditis. It's present in 3 of them. Some people call thyroid peroxidase antibody, they call it anti-thyroid peroxidase antibodies. It's the same thing, my friends. Forget about the name, know what it is, know how to use it. TPO in the exam, someone didn't just hear me, is in all the autoimmune, most of the autoimmune thyroid problem. It's in Hashimoto's, it's in Graves', it's in postpartum thyroiditis. Don't fail it in the exam. So now that we've come to this, can I run you on Graves' disease? Well, I know all of you know Graves' disease in the exam. Graves' disease is the specific features is that the patient will have a diffuse goiter, but no nodules. Diffuse goiter, no nodules. Diffuse goiter, no nodules. Someone is now saying, okay, but I saw a goiter that looks like Graves'. He has nodules. That's Plumer's disease, my friends. Plumer's disease is a goiter with nodules. Graves' disease is a goiter without nodules. Someone is saying, I've heard that name before. Plumer's disease.
Sorry, what disease, please?
Plumer's. Plumer. It is another name for Plumer's disease is toxic multinodular goiter. That's the name you know. The AKT will give you Plumer's. Know the 2 names of everything. Now, and I know I've come into Graves', but let me just distinguish between Plumer's and Graves'. The difference is that when you give them your when you do your thyroid scintigraphy, that's what we say you want to give them thyroid they want to have thyroid uptake. You want to take a picture of the thyroid gland to see if those nodules are uptaking thyroid. You call thyroid scintigraphy. So when you do your thyroid scintigraphy, the difference between Graves' and your Plumer's disease is that Graves' disease will uptake iodine uniformly. But with your Plumer's disease, some nodules will take more, some nodules will not take at all. The nodules that take more, that's what we call hot nodules. The nodules that don't take at all, they are cold nodules. So I don't think you will fail a question when they start to bring these distinguishing factors for you. But I don't want to talk too much about Plumer's disease. I've just mentioned it in passing. If you see it in your AKT, it is toxic multinodular goiter, Plumer's disease. I don't think they want to push you. That's a specialist stuff. But just know it, because it will be one of the options to deceive you. Graves' disease is what they will ask you. Please know that apart from the goiter, which is painless, there is thyroid eye disease. It causes pretibial mixed edema. All these three things that I've said, if you see it alongside with what we call thyroid stimulating hormone antibodies, which is specific for Graves, and you see TPO, your answer is Graves. Let me repeat it. Someone didn't get that. TPO plus TRSA, that's thyroid stimulating hormone receptor antibodies, that's TRA. So TPO plus TRA plus thyroid features equal to Graves. TPO, which is in all of the autoimmune ones, plus thyroid stimulating hormone antibodies, that's the thyroid receptor antibodies, plus Graves picture, that's thyroid eye disease, exophthalmos, pretibial mixed edema, and all the other things you see in thyroid, including thyroid acropathy, is Graves disease. Now, I may not be able to talk much about thyroid eye disease. When I was planning for my own AKT, I wrote half a page on thyroid eye disease. Don't be like me. I've made those mistakes. That's why I beg you, don't do that. The only thing you need to know about thyroid eye disease. So thyroid eye disease is a bulge. You see the eye is bulging due to inflammation, swelling. But what is causing the bulge behind the eye is what they ask you in the AKT. The tissues behind the eye are forcing it forward, and that's why you are seeing a bulge. It is the autoimmune problem. It's the autoimmune nature of the eye disease. So they can ask you thyroid eye disease. I probably would do thyroid eye disease as a topic on its own during the drills. I'll just play around with it. But the commonest cause of thyroid eye disease is Graves' disease. It is rare. And if you are seeing it, it can be found in hypothyroidism. But if you are seeing it in hypothyroidism, it will be extremely rare. It will be more of a patient with Graves. That's what they want to bring out in your exam. The treatment, please think topical lubricant is a treatment. If that fails, the only other thing you can do is radiotherapy. Someone is asking, can you do radiotherapy for the eye? Yes, I've just said it now. Thyroid eye disease, a treatment is radiotherapy. And of course, you know that you have to refer to the ophthalmologist for that. You don't do that. But the only reason why I've dived into thyroid eye disease is because I want to tell you the pathophysiology. The pathophysiology of thyroid eye disease is that the orbit has what we call thyroid stimulating hormone receptors. And it is these receptors which are also found in Graves' disease that cause the eye to bulge out. So what happens is that there's autoimmunity against the orbit receptors. So these TSH receptors in the eye start to fight the orbit receptors and start to damage it. There's a bit of hypertrophy. There's a bit of deposition of collagen. And when collagen is deposited, that leads to the vessels getting engorged. Everything happening in that eye is a chaos. The eye begins to bulge out as if it wants to pop out. Navziger sign is the sign that we use to find out whether the patient has thyroid eye disease or not. I'm not going to bore you much with that. I just wanted to tell you that it is due to TSH receptor antibodies in the eye. So if you see that question in the AKT, why do patients have thyroid eye disease? Is because in Graves is because of the TSH receptor. There are TSH receptor antibodies in the eye causing problem. Simple and short. I've told you about Graves. I can go on and on and on about Graves. Please, pretibial mixed edema, we've talked about it not once, not twice, more than 3 times. It is due to mucin. There's something called mucin. It's deposited by thyroid. It's deposited by hyperthyroidism. So when there's mucin deposit under the skin of a patient, or usually at the shin, then you start to have pretibial mixed edema. How does it come in the AKT? If you are looking for them to write pretibial mixed edema, it's not there in your AKT, my friend. They will say a waxy edematous discolored appearance. Sometimes they may describe it as lizard skin. So lizard skin, discolored, in a patient with thyroid disease, think pretibial mixed edema. Don't fail it in the exam. What are the other features of thyroid? I've just told you that you will see the antibody, the TPO there. Of course, look out for the finger clubbing in thyroid, what we call thyroid acropathy. Thyroid acropathy is like finger clubbing. So some candidates will say the patient has is Graves' disease causing thyroid acropathy, please. Well, cranial nerve palsy can happen, you know why. And of course, proximal myopathy is common in thyroid disease. I don't want to waste too much time. Just know that the TSH receptor antibodies and the TPO are both present in Graves, but it's only TPO that is present in Hashimoto. See the difference. Clincher. TPO alone in Hashimoto's. In Graves, TPO and TSH receptor antibodies. Hashimoto's hypothyroidism picture, Graves' hyperthyroidism picture. How do you now feel these things? You can't. You can't. Okay, so that's Graves. Let's talk about Hashimoto's. Well, in the exam, I don't know how candidates fail Hashimoto's, but I feel unhappy when I see a candidate filling a question on Hashimoto's. So in the exam, Hashimoto's basically presents with a picture. So first of all, it is the commonest cause of hypothyroidism. Let me start from there. The commonest cause of hypothyroidism is an autoimmune condition called Hashimoto's in the developed world, of course. In the developed countries, it will be Hashimoto's. Please note the word developed. Now, what what are the clinchers? Hashimoto's has got a goiter, a non-tender goiter, just like Graves. So you can never use the goiter as a distinguishing factor. But when you try to feel the goiter, it becomes a bit firm and rubbery. Firm and rubbery goiter, hypothyroid picture, thyroid peroxidase present, Hashimoto's. You got your answer. Let me say it in another way. Thyroid peroxidase antibody with anti-thyroglobulin antibodies. Now, this is the type of second antibodies we see in Hashimoto. So I told you the one we see in Graves is TSH receptor antibodies. For Hashimoto's, its own is thyroglobulin antibodies, TGAB, what I call TGAB. Thyroglobulin antibody TGAB plus TPO is automatically equal to Hashimoto's, as to TPO plus thyroid receptor stimulating antibody is equal to Graves. How do you feel these things? I don't know how. That's why I was telling you that when I come to thyroid, sometimes there will be a place I'll just start to run my mouth. This is the place. This is unending. I will have to stop myself. But let me just make sure that you have a bit of Hashimoto's and you have a bit of Graves to be able to identify it in the exam. Now, what is the third one? It is called postpartum thyroiditis. What's that? Is a patient I've told you before, she has just given birth, and this patient is now having she's having thyroid hypothyroidism symptoms. So it starts with hyperthyroidism first of all, and this woman starts to have hypothyroid picture. How long can she have hyperthyroidism? Usually 8 weeks. I told you it's got a dual face. It's what we call two face. So a patient that has just delivered, you do a thyroid function test, and what you find out is that you are seeing a hyperthyroid picture. It's postpartum hypothyroidism phase 1. Watch the patient. After a few weeks, you need to repeat. You repeat. You are now starting to see that it has turned to hypothyroidism picture, and you are seeing hypothyroidism features. That is phase 2. But what has brought it? What has brought it up? Why have I linked it along with Graves' disease and Hashimoto's? Is because it's got TPO. So the topic here is thyroid peroxidase antibodies. You see it in 3 of them. Now that I'm here, let me just finish it, because it's best that we don't leave anything unturned. I don't like it. So if you see a patient with postpartum thyroiditis and postpartum thyroiditis, and the patient is in the hyperthyroidism phase, because you know it's transient, what you need to do is give them propranolol. Do not Well, if it becomes problematic, starts to cause a lot of issues, you can refer. Who do you refer to? Don't refer to gynae, it's to endocrine, my friends. Well, when they enter the hypothyroid phase, what do? We usually do not treat as well. It's usually not very severe. But if the patient enters hypothyroid phase, it can last for 6 months. If the patient is getting severe symptoms, of course, you know what to do, levothyroxine. I just thought I should just mention these things to you. So propranolol will be the only treatment. Otherwise, don't treat in primary care if it's hyperthyroidism. If the patient starts to have palpitation, tremors, that's when you give your propranolol. If it's in the hypothyroid phase, levothyroxine is not usually required, but if the patient starts to have symptoms, please treat. I thought I should talk about TPO. I can just talk about Graves. It will take me like 10, 15 minutes. I can talk about Hashimoto. It will take me another 20 minutes. I thought I should use TPO to expand into these topics. I hope it has been helpful to someone who has been finding it difficult to know these three topics. Well, because we've not had time, if you are still not very confident, that's where the drills come in. That's where the mocks come in. Please, once the mocks are out, register for them. Please don't be missing the drills. You are in September. If you missed it in August, that's fine. Don't miss it in September. I beg you. Right. Painful goiter. Causes of painful goiter. My friends, I give you a question. Is a 48-year-old patient who has a painful goiter. If you have not been hearing me, Hashimoto's is painless and robbery. Graves is painless as well. But whenever we come to painful goiter, think about this man who is 44 years old and has raised ESR. Thank you for crossing the answer, whoever said Dequavians. That's correct. If you have said another answer, the other answer I would have been expecting you to say is amiodarone. Amiodarone is a cause of painful goiter. In the AKT, painful goiter, amiodarone. Painful goiter, Dequavians. Dequavians is a cause, and there's Dequavians tenosynovitis, but there's Dequavians thyroiditis. We are talking about Dequavians thyroiditis. Dequavians tenosynovitis, if you see in a question in the AKT, if you are seeing that they are talking about Dequavian syndrome in the hand, then what you need to do is you need to do Finkelstein's test. Finkelstein's test. That's Dequavians in the finger. Is when anyway, let's not go there. Musculoskeletal will go there. The test is Finkelstein's test. It can pop up. It can be your question one. I tried not to say it, but because I know it can be your question one, I said Finkelstein's test, Dequavians. But this is Dequavians thyroiditis. Dequavians thyroiditis is raised ESR and painful goiter. Amiodarone is painful goiter with starting a new medication. How do you feel these things when they've been put to you like bread and butter? How do you make a mistake? Well, if I say this in the drills 3 times and you still make a mistake, I will take it that you deliberately wanted to fail the question, because the causes of painful goiter, they are not plenty. They are not too much. So I've told you the top two: the Quavians, raised ESR, and a patient that a patient that is on amiodarone has painful goiter. How do you feel then? Well, now that we are talking about amiodarone, let me just talk about amiodarone. Amiodarone, you can see that this is the third time I'm talking about amiodarone. You can see that if you don't know amiodarone, I think you are being wicked to yourself. If you don't know cyclosporin, I think you are being wicked to yourself. If you don't know ACE, unfair to yourself. It's not good. If you don't know beta blockers, what are you doing? Look at propranolol today. We've talked about it in endocrine. We go to cardio, we talk about it. Propranolol is also a treatment in pheochromocytoma. You leave endo and cardio, you go to other places. In psychiatry, it is an off-label treatment for anxiety. It's everywhere. Even that patient, that tall patient in the AKT that has downward displacement of the lens, that her aortic, she can easily have aortic rupture. That patient, the treatment is also propranolol. Someone is trying to think about it. Someone doesn't know that there's a candidate can come in come in a picture can be painted in your exam about a very tall girl. Which one has downward displacement of the lens? Which one has upward displacement of the lens? Downward displacement of the lens is homocystinuria. Don't fail it in the exam. Okay, I'm just going to move on, and then we'll talk about other things. But for amiodarone, it causes both hypo and hyperthyroidism. It causes both of them. Hyperthyroidism, amiodarone. Hyperthyroidism, amiodarone. Don't fail it. It causes the two. So if you get a question, you'll see that it's hyperthyroid. Don't say it's not amiodarone. It can be. Amiodarone, it can also be hypothyroid. I don't want to go into the pathophysiology, how it happens. I just want you to know the clincher in your AKT. Painful goiter, new medication, amiodarone. Raised ESR, self-limiting, painful goiter, decrevian steroiditis. And decrevian is usually due to decreased iodine intake. It's different from amiodarone, which is due to inhibition of an enzyme called 15-deiodinase enzyme. So 15-deiodinase enzyme, what it will do is to affect T3 and T4 metabolism, and that's how amiodarone causes its problem. But as I said, let's not go into that. What's the treatment of decrevians? Now we are here. NSAIDs. Just give your ibuprofen, give your naproxen, they will be fine. I just thought I should mention that to you, because I don't know, if I'm not mentioning the things that will come out in the exam, then what am I doing?